So hello and good evening, everyone. Please let me know in the chat box if my audio and video is good. Just waiting for your comments so that I can start. Okay, so let's start the discussion of the 20 important MCQs asked in the RDX series of medicine. So let me know how was the exam. Again, in the chat box, please let me know how did you go about the exam. Was it easy, moderate, difficult? Dr. Faiz, good evening. Good evening, Dr. Faiz. So let's get started. So what I'll do is we'll have a quick fire discussion of the 20 MCQs asked in the RDX exam. So let me tell you that this is not going to be a very elaborative test and discussion type of session because the detailed lecture is already there in the app. So this will be rather a precise, to the point discussion of the 20 MCQs asked in the RDS exam. And I would expect my dear students also to be active in the chat box. You can let me know what you think is the answer. And a few bonus questions also I'll be asking to the students, the listeners. And let me see how many of you get this right. So Anuj Sharma also, good evening, Anuj. So how do you go about the exam? I hope it was easy for you. Let's start with the first question. Among the following infections, the least common cause of AV block. Okay, so AV nodal block has multiple etiologies. And among the multiple etiologies, you have also got infectious etiologies that can lead on to AV block. So the question is regarding the infectious etiologies leading on to AV block. So what do you think is the answer for this first question? All the following can cause except. Okay, so let's have a quick look at the infectious causes of AV block. Very, very important. Each of these infections, you should know the infections that can lead on to AV block. Number one and most important expected question, Lyme carditis. Okay, Lyme carditis. Second, the bacterial endocarditis, not just any bacterial endocarditis, a complicated bacterial endocarditis with a perivalvular abscess. Number three, viral myocarditis. Number four, Chagas disease. And number five, toxoplasmosis. But the point I want all my dear students to remember is about Lyme carditis. And what about the options? Lyme, Chaga, bacterial endocarditis. So what is going to be the answer? HIV. Now, can somebody tell me in the comment section, what is the impact of HIV on the cardiovascular system? Does it affect the cardiovascular system? If it does affect, let me know in what way. Does it commonly cause an AV block? Remember, HIV would normally affect the coronary vessels, resulting in increased risk of coronary artery disease. There is an increased risk of coronary artery disease. That is number one. Okay. And also it can cause cardiomyopathy. So who's going to answer what type of cardiomyopathy is more common with HIV? Ajay, Pradhan, Anuj, Achan Khan, tell me, what is the most common type of cardiomyopathy? It is usually a dilated cardiomyopathy, DCM. Can arrhythmias occur in HIV? Yes. Very rarely, even AV block also but it is very, very uncommon. And the question is asking about the least common type. Answer would be HID. Let's go to the next question. Okay. Meanwhile, I promised you that I'll be asking you a couple of bonus questions, right? So for my children in the chat box, I'm going to ask one question. Let me see who gets this right. Will AV block due to Lyme carditis improve with antibiotic therapy? That's what I want to know. Come on, I want you to answer in the comment section. Will the AV block due to Lyme carditis improve with antibiotic therapy? Yes or no? Yes or no, tell me. Answer is yes, it can. It'll take a few weeks, but it does improve with antibiotic therapy. Second, bonus question. Congenital AV block. We are discussing AV block, right? Congenital AV block in a child born to a mother with SLE. What is the likely antibody responsible? Who is going to answer? What is the likely antibody responsible? Remember, yeah, I can wait for your comments. I'll take that. I'll wait for the comment section answers, and after that, I'll discuss. Okay, right. Let me just show you the next question. So as you quickly scan through the question, I am just waiting for the answers in the chat box. Tell me. Congenital AV block. Okay, neonatal lupus with, good. I can see Sean Parker, Achyut Joshi. It is usually the anti-Ro antibody. Okay, anti-Ro, and to an extent anti-La as well, mainly the anti-Ro and anti-La. Okay, anti-Ro mainly. Okay, good. Very good. I've got some very good students in the comment section. Okay, let's go to the next question. This one, not so easy, but let me see if you can pick this up. A 33-year-old man presents for evaluation of episodic weakness and headache. He has experienced 5 episodes of hemiparesis over the past 3 years. The episodes last 6 to 12 hours and are manifested by spreading weakness from left arm to left leg. During the episodes, he generally develops a progressively intensifying, moderately severe throbbing headache with associated nausea. Sister and mother experience similar episodes. Neurological examination is normal. Mutation in which gene is responsible for this presentation? My dear students, quickly I'll tell you on how I would have approached this question if this question was put for me. First, I'll quickly look at the age. What is the age? 33 years. Okay, 33 years. And what are the symptoms? Episodic weakness. So he's having periodic weakness rather than a continuous prolonged weakness. Episodic weakness. And is that all? No, he's also having headache. And over the last 3 years, 5 episodes of hemiparesis. Look, for a 33-year-old man to have 5 episodes of hemiparesis over the last 3 years. Is it just any sort of acute onset weakness? Well, it looks like a spreading weakness. So from the left arm, it is progressively involving the left leg. That's the pattern of weakness. And it's lasting for 6 to 12 hours. And during the episodes, he's also having some sort of throbbing headache with associated nausea. Whenever you have got throbbing headache with associated nausea, you're thinking of migraine. So some connection between migraine and some sort of a hemiparesis with a positive family history. What could this be? This could be a familial hemiplegic migraine. As rightly said by Tansi, Anuj Sharma, you have rightly said it is a familial hemiplegic migraine. Now, don't you want to know a few points regarding familial hemiplegic migraine? Well, this is a subtype of migraine with motor aura. Okay, so what you are seeing as hemiparesis is nothing but a motor aura. You have heard of different types of aura. Who is going to answer in the comment section? What is the most common type of aura in migraine? Is it visual, auditory? What type of aura is most common? Visual aura is most common. And this is a rare type of motor aura. So patients can have either a hemiparesis or even hemiplegia. Okay, so what is the hallmark of familial hemiplegic migraine? Along with the headache, you can also have episodic, reversible, unilateral motor weakness on one side. And an interesting point, this sort of motor aura, what is the pathogenesis? Do you want to hear a new term? CSD, cortical spreading depolarization. What does that mean? See, in migraine, you get this aura, right? Visual aura, auditory aura, olfactory aura. This aura occurs because in your cortex, there is some sort of depolarization that slowly spreads. Cortical spreading depolarization. That's the mechanism of aura. Expected MCQ. What is the mechanism of aura? Cortical spreading depolarization. Don't write about, say, vasoconstriction. That is old theory. Okay. Current theory is cortical spreading depolarization. So just like that, if that depolarization occurs in the motor cortex, that is, just imagine through the motor cortex, there is some sort of depolarization that is spreading. You will get weakness. And that is the reason for this hemiplegia, motor aura. Okay. And remember, familial hemiplegic migraine, 3 important types are there and 3 important genes are there. Even if you don't remember all the genes, that's okay. But my dear students, you have to remember what is the gene mutation associated with the most common type of hemiplegic migraine, FHM type 1. FHM type 1, the gene is a calcium channel gene. This is coding for the P/Q type of calcium channel, CACNA1A. That's the gene. FHM type 2, type 3, ATP1A2, SCN1A are the other genes, but at least remember about the calcium channel gene, and the answer is option C. Okay, going to the third question. Which of the following statements about Hammond's sign is false? Now, who is going to answer? Anuj, Dramanul, Jasmine, Sampath, Hridya. Answer this one. Which is false about Hammond's sign? Hammond's sign. Okay. So Hammond's sign is seen in pneumomediastinum. This is a true statement. It is seen in pneumomediastinum. And can somebody tell me how does pneumomediastinum results? Pneumomediastinum results due to 3 conditions. Number 1, alveolar rupture with dissection of air into the mediastinum. That is one cause. Second cause, perforation or the rupture of esophagus, trachea, or the main bronchi. Cause number 3, dissection of air from the neck or abdomen into the mediastinum. These are the 3 important causes of mediastinum. And my dear students, you may get this as a scenario-based question. Rather than just mentioning pneumomediastinum, they might give you a scenario-based. And what is this Hammond's sign? Hammond's sign refers to a crunching, very important. The nature of the noise is a crunching or clicking noise. It is synchronous with the heartbeat and it is best heard in the left lateral decubitus position. So what is the false statement here? Pneumomediastinum, correct. Crunching or clicking noise, correct. Synchronous with heartbeat, correct. Best heard in sitting and leaning forward, galat jawab. Okay, so the answer will be best heard in the sitting and leaning forward position, option D. Option D. Now, I have a bonus question for you. Okay. Any other Hammond have you heard about other than Hammond's sign? Some syndrome or something related to this term? I'll wait for your answers in the comment section. Let me see who answers this. As I wait for the comment, I'll just go quickly to the next question. Okay, right. Which of the following correlates with decorticate rigidity? Decorticate rigidity. Okay. So options you can see on screen. And I am going to tell you in the next 2 minutes, some important points of difference in decorticate and decerebrate. Simple, no? Simple. I'm going to show you a picture. Look at this. This picture is having normal physiology, decorticate rigidity, decerebrate rigidity. Okay, right. Now, what you should understand is that 2 important structures, one in the midbrain, which is your red nucleus, RN, and one in your medulla, which is the vestibular nucleus. Okay, this red nucleus, you can see, is stimulating the flexors of the upper limbs. Yes, what is a normal function? Red nucleus via the reticulospinal tract is stimulating flexors of upper limb. Okay. The vestibular nucleus via the vestibulospinal tract is stimulating extensors, okay, of both the upper limb and upper extremities and lower extremities. UE means upper extremity, lower extremity. Now, what happens is in decorticate, I want everyone to remember this for life, that decorticate means lesion is above red nucleus. Say along with me, decorticate. Rigidity means lesion is above red nucleus. So lesion is above red nucleus means above. So the reticulospinal tract is intact. Reticulospinal tract is intact. Now, when the reticulospinal tract is intact, the reticulospinal tract will cause flexion of the upper extremities. The intact vestibular nucleus and the vestibulospinal tract will cause extension of lower extremities. Okay, because upper extremities, red nucleus has the upper hand. So you will have this sort of a posture. This is called decorticate rigidity because of the intact red nucleus, vestibulospinal nucleus. Now, coming to decerebration. Decerebration for life, remember, the lesion in decerebrate rigidity is between the red nucleus and vestibular nucleus. So you have got a lesion between the red nucleus and vestibular nucleus. Okay, right. When there is a lesion between red nucleus and vestibular nucleus, which tract is damaged? The reticulospinal tract is damaged. Which tract is intact? The vestibulospinal tract is intact. Since the reticulospinal tract is damaged, upper limb, no flexion. It will be extension. Lower limb, intact vestibulospinal extension. This is the decerebrate rigidity. Now, if I tell you option number D, disinhibition of the red nucleus with facilitation of the rubrospinal, correct or not? Correct. Correct. Okay, correct. So the answer is option D. Option D. Now, regarding the Hamann that I asked, I'll give you a hint. Can you tell me what is Hamann-Rich syndrome? Hamann-Rich syndrome. Who is going to answer? Hamann-Rich syndrome is also known as acute interstitial pneumonia. Okay, very important. All these points are very important. Acute interstitial pneumonia. It's a type of interstitial lung disease. Okay, right. Okay, next question, important. Which of the following is the differentiating feature between IBS, which is irritable bowel syndrome, and organic GI disease? So this is a point that I have discussed during my discussion in the DocTutorials app about irritable bowel syndrome and comparison with inflammatory bowel disease. Now, there are certain features that can occur in both. If you look at the options, diarrhea can happen in both. Pain abdomen can happen in both. Mucus in stools can happen in both. So irritable bowel syndrome, if you look, this is the criteria. I'm not going to the details of the criteria, which I've discussed in the app, but you look at this, there is abdominal pain. Patient is having a recurrent abdominal pain, which is one important feature. So there can be abdominal pain in irritable bowel syndrome. Rome 4 diagnostic criteria is the diagnostic criteria for IBS. And yes, you can have recurrent abdominal pain, which should last for 3 months, according to the definition. And this abdominal pain is related to defecation, point number 1. Point number 2, this is associated with a change in the frequency of stool. So you can have either a diarrhea or a constipation. So abdominal pain can occur in IBS as well as IBD. Diarrhea can occur in IBS as well as IBD. Change in the form or appearance of stools, mucus can happen. But can somebody tell me in the comment section, what about option C? What about option C? Stool calprotectin. It is elevated in what? As I can see, Dr. Drimanul Hoda is telling absolutely right. It is elevated in inflammatory bowel disease. So when there is a luminal inflammation, as in case of inflammatory diarrheas that can occur in IBD, what can happen? You can have the presence of leukocytes or certain leukocyte-derived proteins like calprotectin and lactoferrin. This will be there in the stool. Okay, so if you look at this, option C, stool calprotectin, will be there in case of organic disease, which is inflammatory bowel disease, but not in case of which one? Not in case of the irritable bowel syndrome. Okay, right. So that is clear. Answer is option C. So I hope it is clear, Dr. Ahana, Sean, and Anuj. Okay, right. Let's go to the next question. A slightly tough question, but let me see how many of you got this right. 68-year-old male with osteoarthritis of his right knee was undergoing a pre-operative evaluation for knee replacement. He was noted to have an elevated platelet count of 1.1 million and further workup showed a positive JAK2 V617F. What is the next appropriate step? So first of all, this is an incidental finding of thrombocytosis. Okay, and there is a positive mutation, right? So what is going to be the diagnosis? Isolated thrombocytosis with JAK2 V617F. Dr. Kushi, do you think this is present only in polycythemia vera? Did I mention anything about the RBC count? No. So what could the disease be? Any other condition associated with the same mutation? This is essential thrombocytosis. This is essential thrombocytosis. So first of all, my children, please know that the diagnosis is essential thrombocytosis. Clear? Now, for the massively elevated platelet count, what is the problem if the platelet count is elevated? The problem is thrombosis. And I can see Dr. Anuj Kumar Chowdhury is telling in the comment section, start hydroxyurea only. Anuj, can you tell me why? Because I agree, hydroxyurea is important, help to reduce platelet count, help to prevent thrombocytosis or help to prevent thrombosis. But Anuj, why not aspirin as well? Aspirin is also important to prevent thrombosis. Why did you not go for option A and you went for option C? The reason is because what Dr. Anuj said is absolutely right. Do you know why? See, when there is a massively elevated platelet count in case of essential thrombocytosis, there is one problem that can happen which everyone should know. That is, when there is a very high platelet count, you can have the high molecular weight von Willebrand factor multimers. They may be removed from the circulation and destroyed by this platelet mass. So you may have destruction of the von Willebrand multimers resulting in von Willebrand disease. What sort of von Willebrand disease? An acquired form of von Willebrand disease. So there is a problem of this. So if there is an acquired form of von Willebrand disease, again, Anuj, why can't I just start on aspirin also along with hydroxyurea? There is a problem. In any patient with the von Willebrand disease, what is the problem with starting aspirin? There is a chance of bleeding tendency. So there is a problem of bleeding tendency. So I can only go for hydroxyurea. Hydroxyurea to reduce the platelet count. And what about the purpose of aspirin? Is a drug that I can give to prevent thrombosis, but here I'm not giving because of the high platelet count. Okay, fantastic. Anuj, well answered, Anuj. Next, quickly, let's go to the next question. 60-year-old man presents with acute onset right hemiplegia of 3 hours duration. Imaging showed a left MCA stroke. Patient was started on thrombolytic agent, that is alteplase. Now, post-alteplase, there is a neurological worsening that happens 6 hours later, and the CT scan shows an intracranial bleed. His fibrinogen level is low, administration of which medication is beneficial. So what is the problem here? This is a post-thrombolysis intracranial hemorrhage, which is a complication. Now, if such a complication happens, suppose you are a neurologist and there is one patient you have thrombolized, and following thrombolysis, patient developed a bleed. And obviously, what is the first sign of bleed? You can see in front of you, the patient is having a neurological deterioration. So that is when you suspect, oh, could this be a hemorrhagic transformation because of the thrombolytic agent? That is one problem with the thrombolytic agent. So this can result in intracranial hemorrhage. So if at all you get such sort of a suspicion of an intracranial hemorrhage, number one, what will you do? You will stop alteplase infusion first. Because suppose the infusion is ongoing. There are two possibilities. Number one, the infusion goes for 1 hour. And then after a few hours, the patient develops complication. Okay, as has happened in this case. But now there is also another possibility. The infusion is ongoing. And while the time the infusion is ongoing, the patient has developed a complication. That is hemorrhage. But in this case, there is no point stopping the alteplase infusion because the worsening happens 6 hours later and the infusion is only for 1 hour. But if at all it developed during the infusion, you have to stop the infusion. I'm just telling you what is the protocol. Second, you have to send the blood for routines and the coagulation parameters, including the fibrinogen level. And my dear students, very important, everyone should know, very important point. Any patient with the post-thrombolysis bleed, you have to give cryoprecipitate. Very important. You have to give cryoprecipitate. Even if you do not know the dose, that is okay. So you're giving it a dose of 10 units infused over 10 to 30 minutes. And you may have to administer additional dose if the fibrinogen levels. Remember, I told you have to do the fibrinogen levels. And in this case, you can see the fibrinogen levels is low. So in this case also, you will have to give additional dose rather than the first dose of cryoprecipitate that you gave, right? There is another option that you can give. That is tranexamic acid, 1000 milligram IV infused over 10 minutes, or epsilon aminocaproic acid, 4 to 5 gram over 1 hour, followed by 1 gram IV until the bleeding is controlled. My dear students, just remember this. Post-thrombolysis bleed, most important drug, cryoprecipitate. If cryoprecipitate not available, either tranexamic acid or epsilon aminocaproic acid. So what is going to be the answer here? Cryoprecipitate. Okay, cryoprecipitate. Okay, right. Let's go to the next question. 25-year-old patient with dental caries is undergoing dental extraction. Which of the following does not need prophylaxis for endocarditis? How many times has this question been asked? The indications for prophylaxis in endocarditis. You have to know this, whether it be INICET or NEET PG. Please look at this important table from Harrison. I can see many of them answering. Dr. Charul Meena, Dr. Kushi Singla, Anuj Chowdhury, all of you are answering this. So Charul and Kushi, I think you have got it right this time. Answer is option B, that is atrial septal defect. Because you should know that certain heart diseases have got high risk. So you have to give prophylaxis. This is a very important table from Harrison. This has been asked 2 times before in INICET exams. So what are the high-risk cardiac lesions for which the infective endocarditis prophylaxis has to be given before dental procedures? Number 1, if there is a prosthetic heart valve in place. Number 2, left ventricular assist device or implantable heart. Number 3, prior endocarditis. Number 4, unrepaired cyanotic congenital heart disease, including palliative shunts or conduits. Number 5, completely repaired congenital heart defects during the 6 months after repair. Then even a repaired congenital heart disease with some sort of residual deficits or defects adjacent to the prosthetic material. Then surgical or transcatheter pulmonary artery valve or conduit placement, and valvulopathy developing after cardiac transplant. So remember, these are the important high-risk lesions. So previous history of endocarditis, artificial heart valves, and untreated or unrepaired congenital cyanotic heart disease are all indications. And the answer is going to be option D, that is atrial septal defect. Okay, right. That's clear. Now, next, let us see who's going to answer this. Which of the following agents is used in the treatment of refractory ITP? Is it idarucizumab, romiplastim, anakinra, or tafasitamab? What do you think? I'll just tell you in next 2-3 minutes. 2 minutes, most important drugs for ITP. Okay, first of all, what are the first-line agents? You might get questioned like this. First-line agents are steroids. You may also consider IVIG or anti-D immunoglobulin. Point number 1. Okay, right. Number 2, second-line therapy. Splenectomy, rituximab, which is anti-CD20, thrombopoietin receptor agonist, and spleen tyrosine kinase inhibitor. So patients who are not responding to the first-line therapy, who are refractory, you might have to consider second-line therapy. Okay, so what are these thrombopoietin receptor agonists? Thrombopoietin receptor agonists are the romiplastim, L-Trombopac, and avatrombopag, and this can cause megakaryocyte maturation, proliferation, and differentiation, and they will increase the platelet production. Correct? And if you look at this, out of the options, what is the correct answer here? Idarucizumab, no. Romiplastim, yes. Romiplastim is the answer. And Drugs like anakinra and tofacitinib can be used in rheumatoid arthritis. Idarucizumab is actually a anticoagulant reversal for any anticoagulant-induced bleed. That is due to dabigatran-induced bleed. You can go for idarucizumab. Okay, idarucizumab. Okay, and what about spleen tyrosine kinase inhibitor? Let me see if anybody is able to answer that in the comment section. Can you answer? Anyone? Fatima, Anuj, what is the spleen tyrosine kinase inhibitor used in case of the ITB? It is fostamatinib. The spleen tyrosine kinase inhibitor is fostamatinib, which will reduce the phagocytosis of the antibody-coated platelets. Okay, right. Let's go to the next question. Okay, next question. All the following are indicators for tube thoracostomy in the management of pleural effusion, except. So in the management of pleural effusion, in certain cases, you will have to do therapeutic thoracocentesis. But in certain scenarios, you may have to go for a tube thoracostomy. Can you let me know what are the indications for tube thoracostomy? Is it loculated pleural fluid pH 7.3, pleural fluid glucose less than 60, or a positive gram stain of the pleural fluid? I'm going to tell you some important MCQs here. Okay, there is one additional bonus MCQ that you're going to get from this. Okay, so what is the answer? Waiting for your answers. Well, in case of pleural effusion, there are 5 indications where you should go for a tube thoracostomy. Okay, number 1, loculated pleural fluid. Okay, number 2, pleural fluid pH less than 7.2. Number 3, pleural fluid glucose less than 60. Number 4, positive gram stain or culture of the pleural fluid. So the gram stain is yielding an organism. And number 5, the presence of gross pus in the pleural space. Out of all this, you take this into consideration and you tell me what is the indicator for tube thoracostomy. So loculated pleural fluid is an indicator. Pleural fluid glucose less than 60 is an indicator. Positive gram stain is an indicator. But look at option B. Pleural fluid pH of 7.3 is not an indicator. The pH should be less than 7.2. Yes or no? So what is going to be the answer? Option B. Now I've got one additional question. Let me see who will answer this in the comment section. Is it going to be Mohan Bhopale, Anuj Chaudhary, or Anuj Sharma? The question is this. Out of these 5 points, which is the most important indicator, or the one which is the most definite indicator for tube thoracostomy in a patient with pleural effusion? I'll wait for the answer as I move on to the next question. Okay. Out of these 5 most important, most high risk, and which one you have to put a tube thoracostomy? Next one, which pair of disease-modifying anti-rheumatoid drugs are safe to be used in pregnancy? Hydroxychloroquine sulfasalazine, hydroxychloroquine leflunomide, sulfasalazine methotrexate, or leflunomide methotrexate. What do you think? What are the drugs safest to be used in pregnancy? Remember, I cannot be using leflunomide, so I'm cutting that off. I cannot be using methotrexate, so I'm cutting option B because I've got leflunomide there. It's not given in pregnancy. Option C, I'm cutting because methotrexate is contraindicated in pregnancy. Option D, both are contraindicated in pregnancy. But option A, hydroxychloroquine and sulfasalazine, both these disease-modifying anti-rheumatoid drugs, they are the safest to be used in pregnancy. Answer is going to be option A. Okay, is it clear? Yes, that is option A is the answer. Next, let us look at the next question. A patient is noted to have a crescendo decrescendo mid-systolic murmur. Meanwhile, let me just see the previous question. Okay. pH less than 7. No, Anuj, the most important indicator out of all this is the presence of gross pus in the pleural space, which is the most definite indicator. Okay, right. A patient is noted to have a crescendo decrescendo mid-systolic murmur. So there is a crescendo decrescendo murmur, and which is loudest at the left sternal border. And on squatting, there is a decrease in intensity, and standing, there is an increase in intensity. Valsalva, again, there is an increase in intensity. What is the likely cause? First of all, you should know what are the causes of crescendo, decrescendo, mid-systolic murmur. That is point number one, because that itself might help you eliminate certain options here. Okay, which one can you eliminate? See, if you look at the mid-systolic murmur, aortic stenosis, pulmonic stenosis, and hypertrophic cardiomyopathy. So this option, and this option all can produce a mid-systolic murmur. Mitral valve prolapse, MVP, can produce a click followed by a short systolic murmur, which is not typically a mid-systolic murmur. So I'm already eliminating mitral valve prolapse. Now what? Now it is the dynamic auscultation which is going to tell me about the diagnosis. And there is one additional point. The murmur is best heard at the left sternal border. Aortic stenosis ka murmur, it is best heard in the aortic area. And pulmonic stenosis ka murmur is best heard in the pulmonic area. So that itself tells me that this is likely to be a hypertrophic cardiomyopathy. Okay. Now, if I look at this about the murmurs of hypertrophic cardiomyopathy, this one I have discussed in my lectures on the dynamic auscultation in cardiology. I'm not going into the exhaustive details of this table. I'm just going to focus on hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy, any maneuver that is going to increase the preload, which may be either a squatting or a passive leg raising, may decrease the intensity of murmur. Any condition that decreases the preload will again increase the intensity of murmur. Any condition that increases the afterload, like hand grip, will decrease the intensity of murmur, and decreased afterload will increase the intensity. Now, if you look at the options, you can see that the patient is squatting, the murmur is increasing. The patient is standing, murmur is increasing. Squatting, decreasing, standing, increasing, Valsalva increasing. So based on this, you can see this is actually typical of hypertrophic obstructive cardiomyopathy. So answer is hypertrophic obstructive cardiomyopathy. I hope it is clear for you and all of you are in agreement to what I said. Okay, next one. Let's see who's going to answer this one. 38-year-old man with HIV. Remember, my dear children, for your exams, NEET PG and INICET, it's very important topic, HIV. You have to know A to Z. I have discussed in detail in my lectures. HIV is very important. So what is the presenting feature? 4 weeks of fever, diarrhea, weight loss. And they are asking which of the following tests makes the diagnosis of CMV colitis. So there are many possible etiological agents for diarrhea in HIV. So one of which is CMV. And to establish a diagnosis of CMV colitis, which out of this is best? What do you think is the answer? Now, remember, for CMV colitis, CMV can have multi-system involvement. But specifically, if you talk about CMV colitis, please note this very important line. CMV colitis is usually diagnosed based on the demonstration of ulcers on endoscopic examination, combined with histopathological demonstration of characteristic intranuclear and intracytoplasmic inclusions. So you will do an endoscopy and biopsy, which is going to confirm the diagnosis of CMV colitis. The answer is option B. Clear? Okay, going good. Let's go to the next question. 35-year-old female, history of Sjogren's syndrome. So a female with history of Sjogren's syndrome, some laboratory parameters have been given. So what are the key findings? You can see that there is a hypokalemia. Potassium is 3 milliequivalents per liter and urine pH is 6. Okay, urine pH is 6. Now, they're asking about most likely diagnosis. And I've always told you in my lectures, in my rheumatology lectures, as well as nephrology lectures, when you have a patient with Sjogren's syndrome, developing hypokalemia, one important consideration that you should be having in mind should be the distal RTA, also known as type 1 renal tubular acidosis. Okay, so let us see if it is a distal RTA itself. If there is any student who knows that distal RTA or the type 1 RTA is the one that is seen in Sjogren's syndrome, you might straight away go for option A. But again, to just substantiate, tell me what is the anion gap here. The anion gap in the blood is 139 plus chloride plus bicarbonate, which is 127, which is equal to 12. anion gap, the serum anion gap is 12. And we know that 8 to 12 is the normal value of anion gap. So it is a normal anion gap metabolic acidosis that we are probably dealing with. What about the urine anion gap? You can see that the urine anion gap is positive or negative. The urine anion gap in this scenario, the urine anion gap is actually positive. Okay, urine anion gap is positive. Yes or no? Agree with me or not? Just let me know in the comment section. Are you agreeing with me? Yes. Urine sodium plus potassium. What is sodium plus potassium? So we know that the anion gap in the serum is calculated by sodium minus chloride plus bicarbonate. Sodium plus chloride minus chloride plus bicarbonate. And what about urine anion gap? Urine anion gap is sodium plus potassium minus chloride. Yes, urine sodium plus urine potassium minus chloride. So this is in the blood and this is in the urine. This is in the blood, this is in the urine. I know doctors, as doctors, we are poor in mathematics. So tell me, what is the urine anion gap here? The serum anion gap, I got it. But what is the urine anion gap? 15 plus 10, which is 25, minus 12. Okay, so which is around 13. So there is a positive urine anion gap. A positive urine anion gap again substantiates the diagnosis of renal tubular acidosis, which is typically the type 1 renal tubular acidosis. I've already explained in detail in my lectures in the app. You can watch that lecture on the arterial blood gas analysis, where I've explained the concept of anion gap in the serum as well as urine. And you can see there is a pH, urine pH is 6. So remember, in type 1 RTA, the urine pH is above 5.3 because there is a defect in the distal acidification. H plus secretion is defective. So answer is going to be option A, type 1 RT. Okay, right. What are the most common drivers? Who is going to answer this one? Where are the most common drivers? So what is a driver for atrial fibrillation? Where is it typically located? Is it left atrial appendage, mitral annulus, pulmonary vein orifice, or sinus venosus? What do you think? Where are the typical drivers located? Okay, right. Anuj, absolutely right, Anuj. Urine pH more than 5. We know that the RTA with the urine pH more than 5 is the distal RTA. Absolutely right. So they're asking about, many students I know, they might have a tendency to write option A, left atrial appendage. But remember, left atrial appendage is a common site for thrombus in patients who have got, say, atrial fibrillation. But when it comes to the pathogenesis of the arrhythmia, on how atrial fibrillation occurs, in my lectures, I've told you that the pathogenesis is attributed to certain abnormal burst of automatic ectopic firing. And this ectopic firing actually starts in the region of pulmonary vein. So the pulmonary vein is where the firing is actually initiated. And as a result of this firing from the pulmonary vein, you can have re-entry circuit. So look at this, my dear children. The pulmonary vein and ostia is where there is a driver. So that is responsible for the genesis of arrhythmia, resulting in certain circuits within the atria. And what is this left atrial appendage? That is where the thrombus is formed. But the genesis of arrhythmia is in the pulmonary veins. Please note that point. It is an expected question. The answer is option C, pulmonary vein orifice. Got it? Perfect. Let's go to the next question. A 50-year-old gardener presents with subcutaneous nodules of the hand and forearm as shown in the image. The lesions are located along the regional lymphatics and are draining purulent material. Gram stain of the drainage material shows gram-positive filamentous branching organisms. What is the treatment of choice for this infection? So can you see the history is that of a gardener with subcutaneous nodules. Okay, so the lesions are located along the regional lymphatic vessels. So what sort of syndrome is this? Okay, what sort of syndrome is this? What sort of syndrome is this? What sort of syndrome is this? This is a lymphocutaneous syndrome. Lymphocutaneous syndrome. This is a lymphocutaneous syndrome. This is a lymphocutaneous syndrome that we are dealing with. We are dealing with the lymphocutaneous syndrome. And which lymphocutaneous syndrome? Tell me some organisms associated with lymphocutaneous syndromes. Number one, you can have nocardia, especially nocardia brasiliensis can cause a lymphocutaneous syndrome. Sporothrix shrinki can cause. Mycobacterium marinum can cause. Yes, Lokesh, right. So you can have multiple organisms causing actinomycetes. But why am I going for nocardia as the possibility here? Can somebody tell me? Dr. Pujasri, Dr. Jasmine, Dr. Maurya, and somebody has got a name of Eva Bradin in the chat box. Well, that's an interesting name. Okay, Eva Bradin. So you can just let me know the mechanism of action of Eva Bradin as well, the other students. I am sure the person who has put the name, he or she himself definitely knows, but others also can comment. Why this is nocardia is because you look at this picture, this sort of filamentous branching organism. This is the clinching point here, which will tell you that this is likely to be nocardia. This is actually, again, a nocardia producing, you can see the filament, okay, filamentous branching pattern. The answer is nocardia. And what is the antibiotic that is given? It is trimethoprim sulfamethoxazole. Okay, trimethoprim sulfamethoxazole. Okay, let's go to the next question. Which of the following is the most appropriate therapy for a 60-year-old male with 2 weeks history of productive cough, fever, shortness of breath, and chest X-ray showing the following pattern? So tell me what it is. Okay, tell me what it is. So you can see the X-ray with an air fluid level. So when there is a cavity with an air fluid level, what are you thinking of? What are you thinking of? I'm just waiting for your comments in the chat box. What are you thinking of? 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 You are thinking of lung abscess. You are thinking of lung abscess. And in an elderly with lung abscess, tell me, should you consider anaerobic organisms? Should you consider or not? Should you consider anaerobic organisms? Yes. Out of these antibiotics, you tell me based on your knowledge of pharmacology, which of these antibiotics is active against anaerobes like bacteroids? Which is active? I can see Dr. Fatima Rasha. Absolutely right. Clindamycin. Clindamycin should be the answer here because neither ciprofloxacin nor cephalexin or vancomycin has any sort of significant action against the anaerobes. Okay, that's clear. Endocrinopathies that increase the risk of diabetes mellitus, Cushing syndrome, acromegaly, hyperthyroidism, or pheochromocytoma. What do you think? What are the endocrinopathies that increase the risk of diabetes mellitus? Who is going to answer? Who is going to answer? Cushing syndrome? Yes. Acromegaly? Yes. Hyperthyroidism? Yes. Even pheochromocytoma. So all these endocrine conditions can increase the risk of diabetes mellitus. Answer is option D, 1, 2, 3, 4. Okay, these are the endocrinopathies that increase the risk of diabetes mellitus. Okay, right. Option D is the answer. Okay. Next question. Which of the following is not included in the TIMI scoring system? So TIMI scoring system is again an important prognostic scoring system which is used in myocardial infarction. So this is a very important scoring system which helps in making, prognostic assumptions as well. And also it is a guide to make treatment decisions. So this I've discussed in detail in my lectures, but quickly for the time being, this TIMI score, it consists of 7 variables at admissions, and 1 point is given for each of the variables, more than or equal to 65 years of age, more than or equal to 3 risk factors for coronary artery disease, prior coronary stenosis more than or equal to 50%, ST elevation on ECG, more than or equal to 2 anginal events in the prior 24 hours, use of aspirin in the prior 7 days. Use of what? Use of aspirin in the prior 7 days and elevated cardiac biomarkers. Okay, right. Now, if you look at this, age greater than 75 is not the answer because that is included. History of hypertension, hyperlipidemia, tobacco use. Included or not? Included because I told you risk factors for CAD. They are taken into consideration. So I'm eliminating that option. Beta blocker use in the last 7 days. Galat jawab. Kyun? Because you can see it is use of aspirin in the prior 7 days, not beta blocker. So that is false, not included. That is going to be the answer. Beta blocker use in the last 7 days. Positive cardiac biomarkers is also included in the scoring system. But I've told you, elevated cardiac biomarkers, answer is going to be option C. Okay, right. Let's go to the last question. Remember, important one. Which of the following treatments is recommended for the prevention of chronic but not episodic migraine? So you have to tell me what is chronic migraine. So don't think that chronic migraine means long-standing migraine. No, it's not just that. Don't think that anybody who has got long-standing migraine is chronic migraine. The most common migraine that at least many of those viewers who are listening to me will be having will be the episodic migraine that comes in episodes and can last for long. But to be called a chronic migraine, it is when the patient is having migraine episodes where he's having headache for 15 days per month. In a month, if 15 days he's having headache, in a month, 15 days he's having headache, and out of those 15 days, 8 days, no, he's having a full-blown migraine. 8 days, full-blown migraine. This is what you call as chronic migraine. 15 days a month headache, plus 8 days, full-blown migraine. This is what you call as a chronic migraine. And the various drugs for episodic migraine, be it propranolol. For episodic migraine, what are the drugs that can be used? Beta blockers, propranolol, valproate, topiramate, amitriptyline, flunarizine. You have got different drugs. These drugs are not effective or not FDA approved for chronic migraine. They are all FDA approved for episodic migraine. Now, which is one important drug that is not drug, which is the administration that, you give as injection, right? So which is the one that is given for the prevention of chronic migraine? It is your botulinum toxin injection. Botulinum toxin A. Botulinum toxin A is recommended for the prevention of chronic but not episodic migraine. Okay, not episodic migraine. That's it. I think we have had a discussion of the 20 questions of the RDX series. My dear students, please watch all the videos of RDX. Some of them has been conducted, some beautiful sessions. They have been conducted. More exams are in line for the RDX. All of you do take the exam. RDX most important questions for INICET we are discussing. Do attend the exam. Do attend the discussion as well. It is there in YouTube. The exam is open for all. And any sort of queries that you are having regarding your preparation, I shall be happy to guide you. You can message me in Instagram. You can just follow me also in Instagram, dr_Rahul_Rajeev. Okay. And keep following the DocTutorials Instagram page also for notifications about the RDX live exam series. So all my dear children, let me tell you that keep studying well. Some of you may be preparing for INICET. Some of you may be preparing for NEET PG. Whatever it be, give your 100% effort. 100% effort you have to give. You have to be dedicated. Don't be anxious. Don't be too stressed out. You try your best. And at the same time, please have food on time. Keep yourself happy and healthy. If your mind is happy and you stay healthy, you are likely to be more receptive when you attend classes. So don't be too stressed out. All what you can do and what is under your control is the effort that you actually put in. So I want all my children to stay happy and healthy. At the same time, give your best. Okay. So all the best for your exams, and I'll be looking forward to hearing from you after your results as well. Thank you so much, everyone. Anuj, Jasmine, Mohan, Adarsh, Dharani. It was a pleasure interacting with all of you, and stay tuned for other DocTutorials RDX sessions. Thank you so much, and bye-bye.